Okay. 57-year-old male presents with shortness of breath. Faces edematous and multiple. He experiences shortness of breath. His face is dusky and edematous and multiple dilated veins in the upper body. His chest X-ray has a large central mass. How would you assess and manage him? In the dyspnea, dilated veins, dusky veins. In a patient with a mass superior vena cava syndrome, secondary to malignant cause. Concern about superior vena cava syndrome, secondary to a malignant cause. Concern about respiratory. The differentials could include enlarged pulmonary embolus, cardiac causes. Other causes can be classified as malignant and non-malignant. Superior is typically malignant. Apical lung cancer. This was a non-small cell lung cancer. And 10% of small cell lung cancers compared to 2% incidence. Cause of extrinsic compression. Hodgkin's lymphoma. Out other causes could be non-small cell lung cancer, or could be small cell lung cancer, or non-Hodgkin's lymphoma, could be a thymoma, and then non-malignant causes could be infective, tuberculosis, aortic aneurysms. As well, looking at non-malignant syphilitic goals and management to exclude acute airway obstruction. Acute airway obstruction, ensure the patient is stable, history, treat the underlying cause. Okay, so in this patient, my concern is that of a superior vena cava syndrome, which can be secondary to non-infective causes and secondary to malignant and non-malignant causes. Malignant causes can include non-small cell lung cancer, small cell lung cancer, non-Hodgkin's lymphoma, potentially IMS, and also infective causes including tuberculosis, syphilitic enlarged thoracic aortas, and less common causes of pulmonary embolus. So my priorities are to rule out acute airway obstruction and find the underlying cause, including stridal laryngeal edema. So stridal, which can indicate laryngeal edema. Respiratory compromise, if there's any dynamic compromise, confusion. Looking for any signs of stridal, hemodynamic compromise, unstable. I would we're going to take a history. A history would characterize signs usually. Malignancy. Okay. Gradually progressive the time course, gradual. No improves the time means collaterals, obstructive. So what's actually happening here in superior vena cava? Obstructed. Indwelling catheters, edema, medical emergency, PT assessments, SBC, venous collaterals, cough dysphagia, special swelling, venous, dyspnea, cough dysphagia, depression of other structures, venous collaterals, dyspnea, dysphagia, inflammation, P equals to disorder, esophagus, aorta, dysphasia, subspecies phagia. Brain, DX, neurological lymphoma, like to ask about constitutional symptoms, any lung cancer, local invasion, laryngeal nerve, any paraneoplastic syndromes, neurological lymphoma, pancytopenia, bony tenderness, constitutional symptoms, ask about SVC catheters, pacemakers, any symptom from TB infections, and PE as well. So causes could be PE, infected, just a cardiac failure. For signs, exams, first review the vitals as a patient will die with an obstructed airway. So first thing I want to do is double check the vitals, review the vitals. Usually put on the back side as face, facial edema, distension of the arms, legs, positive Pemberton sign, striders, edema, external vein, venous congestion, discoloration, stridor veins, cancer, osteoarthropathy, clubbing, UAC clubbing, Consider video disease events procedure. Let's look at the CT scan. Function tests. First, through the stridal. Patient upright and vesical stenting. Intravenous stenting. Patient upright, hold on, there's the latency radiotherapy. And death. So you could sit the patient upright. Sit the urge of edema. Sit the patient upright, you can consider intravenous stenting. Woman presents with bruising and menorrhagia. Easy bruising and is we can have decreased number of platelets. We can have decreased thrombocytopenia, leukopenia. There can be decreased number of platelets. Decreased quality. Decreased number of platelets. It can be IgG against the platelet antibodies, or it can be immune thrombocytopenic background. It can be microangiopathic hemolytic anemia. We can have a microangiopathic hemolytic anemia. It's going to be thrombotic thrombocytopenic background Prostatitis, TS13 mutation. Or it can be a hemolytic syndrome, virotoxin depletes E. coli, virotoxin depletes platelets. And we have decreased quality, and it can be Glansman's bad cells, genetic meds conditions, genetic meds and conditions, and genetic nosolia, nalapsolia, we have Glansman's thrombocythemia, Then for meds we can have aspirin, and conditions such as uremia, hyperuremia. So TS13, biopsy, skin mucosal menorrhagia, skin mucosal, or we could have menorrhagia. Yeah, you could have a disorder of your platelets. Alright, so we can have this. Secondary associated with drug reactions, infections, and secondary to leukemia. diagnosis of exclusion. Immune thrombocytopenic pepper is a diagnosis of exclusion of bone marrow. Defined as a isolated low platelet, normal bone marrow in absence of other causes. Normal bone marrow. Isolated low platelets, normal bone marrow in absence of other causes. Concerning neurological malignancies, I'd like to clarify sepsis, DIC. Infection, sepsis, TTO. there's your fistula, but that would be internal hyperplasia. So do work on this internal hyperplasia. Renal failure. Prevents ischemia and renal failure. So one is a fistula, blackout reason. Okay, hyperkalemia, it's a fluid overload. Hyperkalemia, fluid overload, metabolic acidosis, past medical history, including whether the being anticoagulated or not, previous access, fistula history, baby history, causes, ultrasound, you will live. Examination of the segment of limb was thrown in the direction of flow of the fistula, steady size upstream. Filter throws, listen for breweries, collapse, remains ideally within 8 to 12 hours. Tissue doesn't need a cannula. It's just really strong. Look at the last one. Anesthetics are just strong. Some kind of cannulation. Okay. Infection must have been very severe. More complicated. Confirmed antibiotic. Shows. pressure, profuse blood, diarrhea, and fever. Erythema pyodermic gangrenosus, ankylosing spondylitis, sacroiliitis, skin rheumatological skin manifestations, pyodermic gangrenosus, sacroiliitis, ankylosing spondylitis, cholangitis, episcolitis, uveitis, and deficiencies that could have a perianal disease. Should be a HCG. Stool microbiology, fecal calprotectin. Stool MCS, parasites, CLFT, LFT, C's electrolyte losses, LFTs, chest X-ray, chest X-ray, looking for 6 centimeters, colitis, Hey, how are you?
I'm good, how are you?
Doing alright. Doing okay.
Did you get signed off?
No, so I think we need do you know Dr. Nazreen Pathan? Do you remember her? She's one of the consultants. So apparently she needs to sign us off. But I've never seen her in all my 4 weeks, so I don't know how she's gonna sign me up. But I guess we gotta just figure that out.
Oh, so the reg said that they couldn't sign you off.
Not the reg, it's that one of the other students asked the site supervisor. She said she wants Dr. Padma to sign us all off. So
that's
we'll see.
weird.
But I think it's a good thing is she gave us a bit more time. She said if you can't see a doctor this week, find her next week. So I have a bit more time. I think that's good because then I can get a few more ward-based assessments signed off by then. So
Yeah, okay.
yeah. Also for the observations, can you get every ward round signed off as an observation, or does it have to be a different one for every different observation you see?
Wait, how many of those do you need?
8.
I'm pretty sure you can just write anything for them, right?
Yeah, that's what I was thinking. Yeah, okay. Cool. With the cases, did you get through everything?
As in, I finished all of them by our last session, so...
All the med cases.
Yes, that's on the Excel, so not the 21 ones, just what's on the... There were only 9 more, right?
Yeah, there was 1, 2, yeah. Damn, okay. I got up to ulcerative colitis, so I still have 3 more left. don't we
That's
go
fine.
through these 1, 2, 3, 4, 5, 6 today?
Yeah.
And then next week we'd finish off med. And should we start psych after that as well?
Yep, sounds good. So I think they were calculating this last time, like 13 or something around there from the 21s as well. So if we add those three on, that'll be about right.
There's 13 more cases from 2021. Sheesh. Okay. Cool. Also on that note, have you thought about all the big deadlines that we have to get things done by to graduate? Like those deadlines for the QUM assignment and...
Oh, I mean, we've all done QM, right?
I haven't.
Wait, what?
Yeah, because I was close contacted during medonc, so I didn't get to. And since then, I haven't been on a ward with long-term patients.
Have you checked? What did they tell you about when you need to submit that?
It's end of TP2, I think.
Okay, so that's in 4 weeks then.
Mm.
Right. No, that's TP1. Okay, so you have another term afterwards.
I'm on GP
okay.
then, which is funky, but I gotta figure it out. Yeah.
No, GPs, a lot of them will have polypharmacy, so that's okay. Hopefully. Yeah, so I didn't think that. I thought everyone who did med had already done the assignment, so that's unfortunate. I feel like you've had so many close contacts.
It'd be like that.
So all we have to do is, for portfolio, just QM, elective report, the National Prescribing Service, and the ethics modules. And as long as you do all your learning plans, I think that's what we need.
Alright, all the ethics, natural prescribing, QUM, and... Is there anything else? So QUM, NPS, ethics, and learning plans. And the reflection. Yeah. And that's due by, was it 25th of March, the elective report?
So I don't think we can submit them yet. She has to mass approve them all. So I think we'll be notified when they're approved. And she said not until April. But I think the elective report's due end of TP1.
Have you already done yours?
Yeah. I just wrote some, got the classic reflection.
Did you have a template that you used from someone else's, or did you just go off the top of your head reflection?
No, I just wrote paragraphs using the graduate tabs. I'm pretty sure no one will read them anyway. Because you just need to submit it saying the portfolio, they just look at it, right?
Okay, alright, cool. I guess I'll get started on that. Mad.
Yeah, no, I think you can do that when you're just a morning, easily.
Okay, we'll go get that done today. Cool. Alright, shall we get started with the cases?
Yeah, sure.
Are you finding that
So
you
it's not-
remember all
Sorry?
the earlier cases as well?
Well, I haven't looked at them since. But the good thing is, we have our med shoots every fortnight with Grim, and he usually goes through 3 random med cases, starting with last year's release, so it's a good revision as well.
That's a Friday morning one, right?
Yeah, and that will be until our Vivus, so that'll be continuous revising and so on.
Cool. Alright, let's get started. I'm just going to get some water and then we'll start.
Yeah.
You want to go first or? I can go first this time. I think you went first last time.
Okay, I don't mind. If you need to eat, that's okay too.
No, it's fine. I'm just having small bites.
Okay. Okay, on his upper body. Chest X-ray has a large central mass. How would you assess and manage?
Okay. In an elderly patient with dilated plethoric veins and shortness of breath, my provisional diagnosis is superior vein vena cava syndrome, and this is most likely secondary to a malignant cause. Malignant causes of SVC syndrome can include your apical lung cancers, so your small cell lung cancers and non-small cell lung cancers. Can also be your non-Hodgkin lymphomas, and then less common causes such as thymomas. I'd like to also exclude non-malignant causes, and this could include tuberculosis, a large pulmonary embolus, potentially cardiac failure, and this is a medical emergency, as the patient may have signs of airway obstruction, which would need to be managed either through supportive therapies, endovascular stenting, and potentially IR as well. So I would first ensure the patient is hemodynamically stable, so I'd perform a brief A to E assessment, specifically looking at the airways, and I'd be listening for a stridor, which would be an emergency in which I would place the patient in a resus bay, consult senior help, and begin hemodynamic stabilization by correcting the airway. Assuming the patient is hemodynamically stable, I would do a targeted history exam and investigations to identify the cause and manage it accordingly. So in my history, I would first like to clarify the signs of SVC obstruction, so clarify how long this has been occurring for. Typically SVC obstruction is quite progressive over months, and actually it may improve due to establishment of venous collaterals. I would like to clarify any dysphagia the patient may have, shortness of breath, any plethora he notes, any changes with exercise and positioning. I would then like to clarify for any differentials. So since I'm concerned about an apical lung cancer, I could ask about symptoms such as hemoptysis, weakness of the arms and limb swelling. Could also ask about hoarseness of the voice, potentially dyspnea due to phrenic nerve irritation or palsies, and I could also ask about symptoms of lymphoma, so B symptoms such as fever, night sweats, weight loss could also point towards a malignancy. I could also ask about any risk factors for DVT-PE, if that's a concern for me. So any recent immobilization, surgery, etc. I could ask about paraneoplastic effects of cancer, so whether there's any Cushingoid symptoms such as weight gain, and I could also ask about symptoms and signs of congestive cardiac failure such as orthopnea, paroxysmal nocturnal dyspnea. I would then move on to my examination, in which I would complete a full respiratory examination. I would also do a thyroid examination if I'm concerned about a goiter and enlarged thyroid mass causing SVC obstruction. I would be looking for facial edema, limb edema, dilated and gorged veins, and I'd also perform Pemberton's test, where I'd hold the arm up for 30 seconds. I'd ask the patient to hold his arms up for 30 seconds to a minute, looking for increasing dyspnea and facial swelling. I'd also do a lymph node exam if I'm concerned about a lymphoma being present. And moving on, for my investigations, my diagnostic investigation to determine that there is a SVC obstruction would be an SVC venogram. I could also consider an ultrasound of any associated veins, such as the axillary vein, to look for any associated obstruction there. However, to visualize the cause of the obstruction, I'd like to do a CT chest to identify whether this is likely a tumor, whether this is an aneurysm, etc. Beginning with bedside investigations, I could do an ECG if I'm concerned about a pulmonary embolus. I would also do, moving on, I would do an FBC, EUCs, LFTs to look for any organ dysfunction that could be associated with malignancy. I could also do coags if I'm concerned about a PE, as a patient may be thrombolized, and I would consider, as this is likely a malignancy, I could consider CT chest, abdomen, pelvis to stage, and also do a PET scan if required. Moving on to my management for an SVC obstruction. Supportive or definitive. Supportive could be positioning the patient upright to reduce the swelling, and then definitive management would be thrombectomy, thrombolysis, or IR-guided. I'm not sure. And then cancer management, MDT setting.
Okay. Alright, okay, and if you had more time, what else would you have in management?
Yeah, so management, I would say there's supportive and definitive management. Supportive management would be positioning the patient upright, reducing the swelling, potentially considering diuretics if there is increased edema, and I would be consulting vascular surgery, and I'd be consulting potentially oncology, radiation, or oncology for concern about a malignant cause. Definitive management could be, there could be emergency stenting of the SVC. We could also consider emergent radiotherapy or chemotherapy depending on the cause, and we could then move to definitive management based on the cause. If this was a malignancy, we'd do a multidisciplinary team setting with radiation oncology, potentially cardiac thoracics, and vascular surgery.
Okay, so you knew your management, yes, that's the timing. I think everywhere was a well done case. You got through all the life threats, and you went through a very comprehensive DDs. I think the main thing is probably history could have been shortened a lot. By the time you finished history, you had 3 minutes already, so that's probably what you had to put down. Okay, let's see. Okay, everything was all good. You had a lot of differentials. A lot of them were quite good. The only extra one I have here is like metastatic. Oh, that's a male. Okay, I have metastatic breast cancer. It was a female, but in this case, not a.
Yeah.
Okay. Life threats. The other one, so you had airways. The other one that can happen is a hypotension. And in my notes, I also have cerebral edema.
Yes, I did notice that cerebral edema. Okay.
History, you had everything. Exam, everything was fine as well. Investigations, bedside ones, I also have ABG in case you're worried about respiratory compromise.
Oh, yeah.
ECG, all good. Imaging, you could consider chest x-ray, but definitively CT was what you wanted, which was good. And then further cancer imaging, which you had. Emergency treatment, that's all good. So you have your endovenous stenting, plus or minus thrombolysis, and radiotherapy plus steroids, if not for intervention. And everything else was fine. Yeah. Good.
Okay, so thrombolysis, stenting, but then also radiotherapy and steroids as well. I didn't mention the steroids. Okay.
I think perhaps in your history, I'm just thinking to cut down. I think it's good because it shows how much you know. But for example, when you're asking all the different symptoms, you can say risk factors for DVT/PE, signs of paraneoplastic, signs of congestive cardiac failure. I think you spend a lot of time maybe going into a bit too much detail, like example, this, and you gave a few for each one, which I think is good, but it just takes a lot of time. So I'm not sure how much detail you need for each of them.
I think you're right. I think we can be prompted if they want us to talk more about the specific symptoms. So I think I should probably just mention headings. Okay, cool.
Timing wasn't too bad. You probably could have. It was probably off by maybe 30 seconds, and you would have gotten through.
Yeah, I think the history is just the main part. You're right. Okay. Cool. Are you ready? just opening up the Word doc. Alright, so the case is a 38-year-old woman presents with a 2-day history of profuse bloody diarrhea and fever. She's diagnosed with ulcerative colitis 10 years ago, and she's been treated with corticosteroids and immunomodulators. She's had no symptoms for the past 3 years and ceased all treatment 6 months ago prior to this presentation. How would you assess and manage her?
Okay, my impression is that this woman is experiencing an acute flare of ulcerative colitis, likely secondary to the cessation of her meds 6 months ago. My concerns in this patient would be causes of life-threatening complications of an ulcerative colitis flare, which would include dehydration, toxic megacolon, and perforation. And my approach to management would be dealing with these life threats with the ATE assessment and then a history and exam to determine the state of her ulcerative colitis, and then conduct and then perform short-term and long-term management in an MDT setting. My differentials for her presentation would include other causes for diarrhea, which may include infectious causes, as well as pseudomembranous colitis in this situation. So, beginning with my ATE assessment, I would mostly be focusing on circulation, given the bloody diarrhea. So, I was just assessing for signs of hypovolemic shock, and as well as a quick abdominal, just quick signs for peritonism or septic shock that may have occurred as complications of this flare. So, moving on to my history, I would like to know, assuming that she's stable, I'd like to know the history of the diarrhea. We know it's been 2 days of bloody diarrhea. I would like to further characterize the stool, so the volume, the frequency, whether it's always bloody, whether the blood is dark, or whether it's on the outside of the stool. I would like to know whether it contains a lot of mucus, and the frequency, and this will help stage the severity of the flare. So very severe would be more than 6 times a day, which would have different management. So I would also like to know associated symptoms, any pain, cramping, whether there has been any loss of appetite, nausea, vomiting, any other constipation, and I would also like to know any other constitutional symptoms such as fever that may be associated with inflammatory bowel disease as well. Given this, I would also like to know complications that may result in hypotension, syncope, any signs of dehydration, and I'd also like to know if any urinary changes to rule out any, for example, AKI. So, given in the history, I'd also like to know the history of the ulcerative colitis, what meds she was on when it was diagnosed, any results on previous colonoscopy, biopsies, the current management, and the reason for stopping meds, as well as a brief screen for extraintestinal manifestations of disease. I would also like to rule out differentials, so by also asking any recent travels, sick contacts, immunizations, and recent antibiotic use. Moving on to examination, I'd like to know vital signs, as well as a general abdominal exam, in particular ruling out peritonism firstly, and severe abdominal pain. I'd also like to identify any masses, as well as a digital rectal exam given the bleeding, and then a general systems review. So my investigations of choice would include at the bedside a urinalysis just to rule out any urinary pathologies. I would do a full blood count, CRP, ESR, EUCs, LFTs, all for baseline and for inflammation, and to assess the severity of disease. I would like to also obtain stool samples, so stool MCS, OCP, fecal calprotectin, as well as C. diff toxin. I may also do stool PCR for any other viral antigens. And imaging-wise, I would like to do an abdominal X-ray to rule out toxic megacolon or pneumoperitoneum. And ideally, I would do a flexible sigmoidoscopy with biopsy to assess disease. Moving on to management, assuming that we've stabilized her, management will depend on the severity of disease. So severe disease, I would like to do high-dose intravenous steroid therapy, and I would also add a 5-ASA agent and azathioprine. And if this would fail, I would continue with medical salvage therapy. If there was evidence of toxic megacolon, this would warrant urgent surgical referral, nil by mouth, intravenous fluids. And if there were no severe or emergency signs, then I would just commence rectal or oral 5-ASA inhibitors and consult gastroenterology for long-term UC management.
Okay, nice. You did very well for this case. Wow, good job. All right, let's go through it. Things you did very well. Your differentials were good. Your AT was really good, and your priorities were mentioned very well. You had a really good understanding of investigations and your overall management. Things to mention. Differentials are all really good. This is less likely in this case if the patient doesn't have the risk factors for it, but you could also consider ischemic colitis. So since you mentioned pseudomembranous as well, that could be another differential. And I know it's like much less common in this case, but if the patient is older, malignancy could also be a concern. But I think it's fine you didn't mention it for this case because you didn't have the time. But yeah, nice. Your AT was really good. You mentioned your priorities were toxic megacolon, perforation, and dehydration. I think you could just rephrase the dehydration into hypovolemic shock, because that's when it would be a major medical emergency. AT was all really good, nothing to say there. Your exam was also really good. You're looking for signs of perforation and also extra-articular manifestations, hence why you mentioned the systems review. If the examiner did ask you what the extra-articular manifestations are, what would you say?
So I would say extra-intestinal manifestations would include musculoskeletal, such as overlying rashes, arthritis. They may be ocular, such as a uveitis. Also in abdominal exam, the other ones I can think of would be like a PSC causing a jaundice or something like that. I can't think of any. Oh, and then I guess you have the respiratory. Or is that something else? No.
I think that's more rheumatoid.
Yeah, I'm getting confused now. Okay, you know that. Is there anything else?
With skin, there's like erythema nodosum and pyoderma gangrenosum, which is more common with UC. You got the primary sclerosing cholangitis. That's seen more with UC. There is like with MSK, you could mention the specific things like you could have ankylosing spondylitis, so spine arthritis, and sacroiliitis as well. Any others? Eyes, episcleritis, uveitis. But that's all I can think of. Anything else in the notes? There's like fistulas as well. But that's more, I think,
Crohn's.
Yeah, more on Crohn's, you're right. And then gallstones with the Crohn's as well. Cholesterol stones. Yeah. Anyway, but good, really good job. Moving on. I'm going to go straight to management because your investigations are all perfect. You got fecal cow protection and everything, so that was really good. Serology is the other thing that they have here. You could do like your PN cuff for UC, and you could do your anti-Saccharomyces cerevisiae antibodies and Crohn's. I don't know if they actually do that in practice, I just got it in your notes here.
Is that
ASCA. Yeah,
that's
ASCA for Crohn's and PN cuff for UC. But anyway, moving on to your management, I think your management was really good. I think you could just signpost what the goals of management are, just so you highlight that, because it's got quite a good list of things for UC. What would you say would be the goals of management?
Well, first would be stabilization, then we have like symptomatic management, and then long-term reduced progression of disease and quality of life.
Yeah,
that's what I have.
That's
and
pretty
monitoring.
much it. Yeah, reduce inflammation, induce remission, and then prevent further complications and infection, which you got. Nice. And you're like your actual medications, pharmacology was all perfect. I got the same thing. I've got like first line glucocorticoids, second line immunomodulators, third lines. They mentioned biologics as well. Could be mentioned, but you got you. I think that was a P+ management. Any questions?
I think that was all okay.
I had a question for SVC obstruction. Is that a medical emergency or a surgical emergency? What would you say?
Yeah, I wasn't sure. In my notes, what do I have? I have medical emergency, but because the emergency management ideally is the endovascular stenting. Is that counted as surgical or I don't know.
I thought it was surely it's like an interventional procedure, right? Like IR or someone would be doing that, I can imagine. But sure, if it's a medical emergency, we'll go with that.
Yeah, you said medical, didn't you?
Yeah, I wasn't sure in retrospect.
Yeah, I mean, it's in a medicine viva, so you can't go wrong if you say medical emergency.
Oh, I'm pretty sure we've had a couple surgical ones as well, but...
Okay, or if in that, this is an emergency. Okay, I don't know. I'm not too sure, honestly.
This is an emergency. Let's do it. Alright, cool. Good job. That was really good. Give me 1 sec. Let me close my notes. Okay.
Okay. So we have let's do this one. A 29-year-old woman presents with easy bruising and menorrhagia. The only hematological abnormality is a platelet count of 52, and then bracket 150 to 400. How would you assess and manage?
Okay. In a woman of childbearing age with isolated thrombocytopenia and no other signs apparent from the stem, my provisional diagnosis is immune thrombocytopenic purpura, and I would like to exclude other disorders of primary hemostasis. This could be quantitative disorders such as microangiopathic hemolytic anemias such as thrombotic thrombocytopenic purpura, hemolytic uremic syndrome. I'd like to also exclude qualitative disorders of platelets. So this could be congenital causes such as Glanzmann's thrombocythemia or Bernard-Solier's disease. I'd like to also exclude other medical conditions such as hyperuricemia and also certain medications such as aspirin. DIC and HELP syndrome would also be lower down in my concerns at this moment. So my approach would be, number one, assuming the patient is hemodynamically stable, I'd like to do a targeted history, examination investigations to identify the cause, and an appropriate management with consult with hematology. In this case, it would likely be glucocorticoid therapy. Beginning with my history, I'd like to clarify the symptoms that the patient has. She's got two primary presenting complaints, which appears to be the bruising, but also the menorrhagia. So I'd first of all like to clarify the bruising. So how long, so what kind of bruising she has, the size, any bleeding, whether there's delayed bleeding time. I'd also like to clarify where the bleeding occurs. Is it more superficial or is it deep bleeding such as in the joints, any hemoporosis, the hematomas, etc. And that would likely differentiate between secondary and primary disorders of hemostasis. I would also like to clarify the menstrual history, so what her normal menstrual cycle is, how much bleeding she typically uses, so pads used per day, etc. And also quantify whether there's clots, any other associated symptoms. Moving on, I'd like to exclude some of my differentials. Immune thrombocytopenic purpura can be secondary to malignancy, so I'd like to screen for signs of leukemia. So this could include bone pain, petechiae purpura, signs of pancytopenia. I'd like to also ask for symptoms of infection, which could also cause ITP, so any hepatitis B, C symptoms, HIV, and also any medication she's currently on. I'd like to also exclude infectious cause, so I'd like to do a quick travel screen, whether she possibly a sexual history, and and signs of infection such as fever. Moving on to my examination, I would like to examine the skin for petechiae, purpura, look for any signs of jaundice. I'd like to do a lymph node examination, looking for any signs of lymphadenopathy consistent with lymphomas. I could also like to do look for any bony tenderness, and I'd like to also do a gastrointestinal examination looking for splenomegaly. I would also like to I'd like to do a vaginal examination, as patient did complain of vaginal bleeding, and just identify if there are any structural concerns that I have. Moving on to my investigations, as she's a pregnant woman, I'd like to do a beta-HCG first. Sorry, not pregnant woman, a woman of childbearing age. I'd like to do a beta-HCG first. I could also consider doing a full blood count, EUCs, LFTs, and also consider doing coags. I'm looking for any signs of pancytopenia and any. I'd also like to do a blood film, look for any evidence of any blasts, and if I'm concerned, I could consult hematology regarding doing a bone marrow aspirate or more invasive procedures. I could also look at, in the coags, the APT, PT, look for any secondary disorders of hemostasis, and EUCs look for hemolytic uremic syndrome and acute kidney injury. For now, that would be it. I could do a hemolytic screen as mentioned. And then moving on to my management. For ITP, my primary management would be that of glucocorticoid therapy. This is a diagnosis of exclusion, so I would have liked to exclude all the other differentials that I've mentioned earlier. If this were to be a leukemia or a lymphoma, this would be managed in a multidisciplinary team setting with radiation, medical oncology, and hematology as well. If this were to be a more acute complication such as DIC or HELLP syndrome, this would be managed with the consult of seniors or obstetrics and gynecology respectively. Supportive therapy could also include blood transfusions or platelet transfusions specifically. This is particularly if the platelet count is below 30. And is that how much time?
Treatment for the menorrhagia would be different.
I forgot to mention I would have done a transvaginal ultrasound, given she has menorrhagia. For management of the menorrhagia, we could consider medications to stop or decrease the amount of bleeding. I think tranexamic acid could be one option.
Yeah. Good. Okay. Cool. That was very good. Let's see. I don't have too much to say overall. You had a lot of differentials as well. A lot of heme ones. So I feel like heme is one of those specialties that are a bit ambiguous in terms of two that I have in my notes as well that you didn't have was also SLE.
Oh, right, with hematological abnormalities,
Yeah, but unless you're thinking of it, it doesn't come to mind immediately, but you had everything else. So even your microangiopathic from the hemolytic anemia. Yeah, that was good as well. That was all good. History. That was good. You could have asked family history as well, did you?
No.
Okay. And all your causes of ITP were very good. Comprehensive. Good menstrual history. Okay. And it was otherwise good differentiating primary and secondary hemostasis. I have nothing else to add for that. Exam, I think had everything there. Investigations, the only extra ones would be for the SLE, like a screen for that, but everything else was good. Treatment, transfusion, which you heard of severe, and steroids. I also have intravenous
pills are just progesterone only, right? Okay, that makes sense. Any questions? Would you say like HIV, Hep C serology? Do you have that as well?
I don't have it in my notes. I think it would be if you think it came up in the history. I don't know if you would routinely do it for thrombocytopenia. I don't know. Do you have it?
They have it, but yeah, I don't know if they actually do it or not.
I think there's no harm mentioning it because I guess you can just rule it out.
Yep. Okay. Nice.
Well, that was pretty good. Very comprehensive. A lot of things you talked about I didn't even think about, so all good.
Right. Cool. Your turn. I'm evil. Alright. Got a good one. So the case is an 18-year-old man is leaving for a year's holiday, trekking through Southeast Asia. What advice would you give him regarding staying healthy?
Okay, so in this man who's presenting, my main concern would be travel counseling. So my approach to this patient would be identifying his plans for travel, his current baseline and medical history, and then providing advice and pre-travel management, which would include vaccinations as part of that review. So I guess I would begin this consultation with gaining a brief history and identifying what this man plans to do and where he's going in Southeast Asia. So I would like to know when he's going, which countries in particular he's visiting, as there are different risks associated with each one's, the duration of stay, who he's going with, and the planned activities, which include going to rural areas, contact with animals, any sexual activity, food and drink, altitude, climbing, and so on. Once I've gained an idea of what activities will be done overseas, I would also like to gain a medical history, so this patient's current medical conditions, whether he has any immunocompromised, vaccination status, and previous current medications, any allergies, as well. And now I would also like to just do a brief examination, just vital signs, body habitus, any signs of active infection or disease, but otherwise, if he's a healthy young male, no further exam at present. In terms of investigations, depending on the vaccination history, it would be a good idea to obtain serology just to inform any booster shots that may be required. However, no other investigations would be particularly necessary. The main thing in this case would be providing management and counseling. A lot of this would be travel advice, which is mostly non-pharmacological. So I would begin by saying what this patient needs to be aware of and the risks of traveling in Southeast Asia. And these risks may be during travel and during the stay as well. So during travel, I would suggest a first aid kit, bring some medications that the patient needs if they need them, as well as general antipyretics, antihistamines, they may need antibiotics, as well as antiemetics. For the travel there, I would suggest mobility, hydration for DVT prophylaxis, as well as motion sickness tablets if necessary. I would advise them to obtain travel insurance before going ahead, as well as general advice while there. So food and drink, I would say don't drink unbottled water, make sure the food is cooked, no raw solids or raw meats. Obviously, no swimming in open areas and safe sexual activity, as well as enclosed shoes. And importantly, in Southeast Asia, being aware for malaria. So this would include mosquito nets, not traveling in dust and dawn, covered clothing, insect repellent, and possibly malaria prophylaxis, which would include doxycycline. In terms of particular vaccinations, I would ensure this patient is up to date and give them, if not, MMR, DTP, influenza, COVID vaccines, as well as more specific Southeast Asia ones, including yellow fever, dengue fever, cholera is high risk, rabies. I think those are the main ones, but I would also provide fact sheets and check the travel guidelines for that. Let's see. So there are other things
Okay,
there.
questions. So you mentioned malaria prophylaxis. You mentioned doxycycline as one medication that can be used. Do you know any other medications that can be used for malaria prophylaxis?
Other than doxycycline, you may also use fluoroquinolones, I believe. But doxycycline is the most commonly used. Yeah.
Okay. And would you recommend this patient get the TB vaccine, to the BCG?
So the tuberculosis vaccine is currently advised, I don't believe, but I don't know actually, but I don't think it's routinely given.
Okay. And last question. You got everything else? Nothing else I can say. Yeah. All right. Good. All right. That's time anyway. So let's go through it.
It's like it's such a messy station.
Yeah, there's like so much management to talk about in non-farm. So much non-farm. So, all right, let's go through it. Things you did very well. Your goals are really good. So you assess the patient's risk. You then advised him, and then you mentioned immunizations. I think you can also just throw in immunizations and prophylaxis as kind of like a signpost, because those are two slightly separate things. For your history, all really good. Your immunizations, activities, you mentioned like food, drinks, sexual activities, travel, animals, all of that was really good. Even altitude, which was really good. You mentioned vaccination status, allergies. You mentioned this later on, but you could also just throw in like the assess their DVT risk, the history, or you can even put that in, so that'd probably be in the history. Nice. For your exam, nothing to say, obviously. That was perfect. Investigations. Did you say investigations?
I just said serology.
Yeah, that's all that's here. Like, if you want to determine the dose for boosters, like if they're eligible for boosters, then you could consider serology for maybe Hep B, but otherwise not indicated. Really good. Otherwise, your management, I really liked how you broke it down into before travel, during travel, after travel. I think you could just categorize that more because you went between the different things, but honestly you got everything, so that was P+. But like before travel, the whole health insurance, DVT risk, during travel, what they need to be doing, specific things like malaria, rabies as well, and then sexual activity, food and drinks is all really good. For malaria, what I was probing you in is the drug of choice, and you nailed this because you said be looking at guidelines and ETG to determine the appropriate prophylaxis, so you had that safety net there, but it depends on the type of, so the region they're going to, so what species of the Plasmodium protozoan is there. So if they're chloroquine sensitive, you would give chloroquine as prophylaxis. So if they're going to an area which has chloroquine sensitive Plasmodium. If they're going to a region that is known to have chloroquine resistant Plasmodium falciparum, then you would consider the things you mentioned, just doxycycline. In actuality, there's 3 meds that I've got here. They use doxycycline, mefloquine, and malarone. So those are the 3. So I don't have any fluoroquinolones in my notes, like ciprofloxacin. But
I think I got confused between chloroquine and fluoroquinolone.
No, that's fine. They all sound the same. Yeah, they all sound the same. Yeah, so you could consider it's sensitive chloroquine. If not, you do your prophylaxis with doxycycline, malarone, mefloquine, and you just mentioned you would, you go into ETG regarding the dates, because like you need to start some of them 1 week before they travel and continue it 4 weeks after they travel. So you could mention, you'd counsel the patient on how important it is to continue that therapy even after travel and before travel. Otherwise, really good. TB's it's dependent on the patient's concerns. It's only 50% effective, so it's not typically indicated as well. I think the one vaccine I don't know if you mentioned was typhoid.
Yeah,
But look, there was honestly so many. There's DTP, MMR, influenza, COVID, rabies, TB, FA, typhoid. So I definitely would have mentioned all of them.
I just don't so much on these counselling things. I'm like, I don't know how to structure this.
So much to it.
Right. Well, I guess it's good if we can give this advice to people to go travelling more these days.
I really liked how you said COVID vaccine, because these nuts didn't have it, and I was like, it's so common sense. How am I forgetting this simplest thing?
It's like exam versus real life. And you're like, nice. Okay. So that leaves us with 2 more.
Oh, don't laugh like that. It's evil. Let me close it.
Alright, so obviously I've given you the harder one, which will be fun. Okay, are you ready?
No, let's do it.
Okay, we have a 57-year-old male, usually on home hemodialysis, presents because his AV fistula has stopped working. Noted 2 hours ago that the usual thrill and bruit are not present. Last dialysis was 2 days ago. How would you manage?
In a patient with reported loss of thrills and recent dialysis, I'm concerned about a thrombosed arteriovenous fistula. This could be secondary to a stenosis and associated intimal hyperplasia. My main priorities in this case would be, number 1, to assess and ensure there is no limb ischemia, to also ensure concurrent continual management of his end-stage renal failure, and number 2, to aim to salvage and restore that arteriovenous fistula, ideally within 18 hours or so. I'd like to begin, number 1, by ensuring the patient is hemodynamically stable, and I do a focused history. In the history, I'd like to clarify when the patient last felt thrills and bruits. Ideally, they are to inspect the AV fistula site 3 times daily. I'd like to ask when they received their last dialysis, any abnormalities they noted, and I'd also like to clarify the time course of dialysis and characterize this patient's end-stage renal failure and natural history of disease. I'd like to also look for complications. So for limb ischemia, I'd be looking for any evidence of paresthesia, pallor, any edema, swelling, or pain in the limb. I'd like to also quickly examine if it's neurovascularly intact, as this is an emergency. If so, I would also look for signs of end-stage renal failure, so any life-threatening complications. So this could include any fluctuating consciousness secondary to hyperuricemia, any evidence of metabolic acidosis if there's changes in the patient's respiratory rate, etc. Any evidence of palpitations, which could concern me into hyperkalemia. Moving on, I'd like to also do ADLs as well, assess the functional status of this patient in the context of kidney disease, as it is a palliative condition. I would then move on to my examination, which would include a examination of the AV fistula. So I'd like to feel for thrills, listen for bruits, and compress the sides, looking for any evidence of downstream or upstream obstruction. I'd like to also lift the patient's arm up and look for evidence of collapse of the AV fistula. which is typically normal. I would then examine the limb, as I said, for evidence to ensure it's neurovascularly intact. I would then do a focused kidney examination, so assess the fluid status for the patient, do a cardiac auscultation, but lock the kidneys as well, and look at the skin for any evidence of petechiae purpura, and also look for any fluctuating consciousness. Moving on to my investigations, I would like to do, number one, diagnostically, I'd like to do a duplex ultrasound of the AV fistula to confirm that there has been an obstruction. However, beginning with bedside investigations, I would like to do ECG, looking for signs of hyperkalemia. I'd then do EUCs, assess kidney function. I could then consider doing coags if I'm concerned about if we're going to thrombolize this patient for management. And I could also consider baseline LFTs and, as we mentioned, a duplex ultrasound. I could then... Okay, moving on, I would then do management, which would be number one, I'd be consulting the renal team regarding this and potentially also vascular surgery. The options definitively for a blocked AV fistula is that of either medical thrombolysis, endovascular stenting, or creation of a new AV fistula. So I could also consider supportive therapy. In the meantime, if the patient has life-threatening symptoms of renal failure, we could consider ICU admission and insertion of a central line and dialysis that way. We could also consider supportive therapy, so managing the symptoms and signs. So hyperkalemia could be managed with concussion gluconate, insulin dextrose infusion, salbutamol resonium. Acidosis can be managed by providing a bicarbonate infusion, etc.
Good, and then it's time. I think I don't have any. Okay, just in general. What do you know generally what would make a good fistula? Any signs looking at a fistula that would make you a bit worried that it isn't doing so well?
If there is increased pressure required from the dialysis machine to run dialysis, if there's increased bleeding after dialysis, that could indicate some evidence of obstruction. If the fistula does not collapse and the arm is raised. And then there are also details regarding the size of the fistula, as once it's placed, forgotten details.
Okay, that's fine, good. Okay, so, very good. I think your main concerns were excellent. It was the ischemia and the acute renal failure complications. Okay, let's see, nothing to add there. So in your history, very good about your fistula care, history of dialysis, kidney disease. You then went on to the limb, which was good, so the signs, the symptoms, paresthesias, pain, and so on. And then you went into the renal failure, so that was good, the two things going on there. The only thing is maybe you could have put in like the consciousness, acidosis, hyper-K, just in your beginning as you went through your ATE. So ATE, just to rule out in the beginning, and then you go into your history. But I don't know if that was important.
That makes sense.
Anyway. Exam was good. Examination of the fistula was very good. And for the limb as well. So when I asked about signs of the fistula, so generally a good fistula, do you have the rule of 6 in your nose?
Yeah, but I did not study that. Yeah. What is it?
Yeah, I mean, I wouldn't have studied it except they told me in Reno when I was there, so that's how I knew it.
Nice. Please teach.
Yeah.
Please teach.
Yeah, so pretty much rule of 6, so I'm sure you have it in your notes, so 6 centimeters, not less than 6 from the surface, 6 millimeters wide, and needs 6 weeks to mature, and need about 600 mils of flow. when you're examining the fistula, warning signs would be if it's very aneurysmal, so if it looks very stretched, and if it looks like it's very thin, it might be a sign that it's going to burst. And if there's a lot of scabbing on it as well, they can also burst. And when you're feeling the bruit, you want to feel nice and continuous, not interrupted, as it means it's stenotic.
Okay, so interrupted bruits. Yeah, I actually didn't understand like the testing for stenosed AV fistulas because it was telling how to determine if it's an outflow or inflow stenosis. Did you learn that as well?
So I did not learn the difference between an outflow or an inflow stenosis, but I did do the lifting the arm test though, and I think the main thing is if you lift up and you're feeling the bruit and it doesn't collapse, then it means, I guess that would mean it's a proximal stenosis. So I don't know if it's an inflow or an outflow. I don't know which direction. Going back to the heart, it has a stenosis because it's not collapsing. It's getting stuck, right?
And then your rule of 6 is at 6 week post creation, it should be at least 6 millimeters wide. What did you say about the surface?
Less than 6 millimeters below the skin.
Be less than 6 millimeters. Less than 6. Okay, so if it's like very hard to palpate, that's bad.
Yes, you don't want it too deep.
Okay. Right. Then 600 ml. And how do you tell the flow rate at 600 ml? Is that through dialysis? It looks like it's 599 ml. Alright, cool.
Yeah.
Rules of 6.
Okay, investigation's all very good. Anything I would add is BCG.
Yeah.
And management, good. So good teams. You had the definitive management. You had the dialysis with the central line, which was very, very good, and treatment of hypokalemia. I don't have anything else to add there. So I thought that was pretty good.
And here I've got frismide as well for fluid overload symptoms.
Oh, okay, yeah.
Alright, cool. I still don't understand why it should collapse. I guess when you raise your arm, you're like increasing the venous return, so it should be less flow through the AV fistula.
So it's like I think the main thing is if you feel like it's pulsing through with the same pressure when you lift it up, it means that there's less. It's like I said, there's less venous return. So the venous return has been obstructed. So it hasn't collapsed. Yeah.
Cool.
Does that make sense?
It makes sense in the sense that like if the bruit's still there, there's probably some stenosis going on that's like keeping blood in and turbulently flowing through. Not bruit, the thrill, sorry.
I mean, the point is the thrill's still there. It's just decreased.
Okay, continuous thrill, but it's decreased. Alright. I'm trying to understand. In my head, it's like if you lift the arm, increase the venous return. Should there be more blood moving through the AV fistula now?
Oh, but the fistula is quite it's quite distal. So when you lift it up, most of the blood would have come down.
Oh, okay. Right. Okay, that makes sense. Yeah. Got it. Yeah. Cool. Alright. Now you have the case. The typical intake case.
I'm getting this stupid.
I actually saw this so many times at hospital. I feel like it's good to have a little mental flow chart. But imagine getting this as your med case after all the studying SLE, shingles, RA, pseudomembranous colitis to get a. Okay, so your case is a 68-year-old man has been in hospital for 6 days, receiving intravenous antibiotics for prostatitis, which need to continue for another 4 days. You are the intern on call, and you've been asked to replace the tissued cannula. The patient is complaining and is refusing this cannula and does not want another one. How would you manage this situation?
Okay, so in this situation, there are several competing interests, which include, firstly, this patient has the need for continued intravenous antibiotics because of his acute prostatitis, and secondly, he may need another IVC, which he doesn't want to. And then we also have the issue that this patient may become aggressive or non-compliant, and it goes against his autonomy as well, which we will need to balance up when dealing with this patient management. So my approach to this situation would be, one, to assess and review where the patient is at and what management he needs. Secondly, to see whether he does need continued intravenous antibiotics. And thirdly, whether he does need a new IVC and what alternatives can be given, and if not, communicating this to the patient. So to begin with, what I would like to do is review the patient. So I'd like to be completely up to date with the patient's notes, the history of the prostatitis, the antibiotic therapy before seeing this patient, so I know what to do, what to ask, and where to go from here. And then when I go to the patient, I would like to know, I would introduce myself, I would ask what has happened, getting the patient's understanding of their condition and what happened to the cannula. I would also like to know the history of the prostatitis, so the urinary symptoms, the systemic symptoms, as well as the improvement in symptoms with the intravenous antibiotics, and any symptoms associated with the any bleeding risk and signs of infection from that. What I would do next is review the site of the cannula. So I would assess whether it has truly tissued by whether I am able to flush it, whether there is any surrounding tissue edema, and any overlying bleeding or cellulitis. And I would have that removed and dressed as necessary. Now, whether this patient requires a new cannula or not, this will depend on consultation with the treating team, and ideally, what I would like to know is whether the antibiotics still need to be intravenous. So ideally, antibiotics should be transitioned to oral when the patient can tolerate oral, when they are not hemodynamically unstable, or when symptoms such as fever have reduced. So this would depend on how the patient is now and according to guidelines. If this patient does require 4 more days of therapy, it may be appropriate to insert a peripherally inserted catheter as an alternative. But if he does continue to need an IVC, I would communicate this with the patient, explain them clearly, listen to their concerns, and then attempt to cannulate them by finding the most appropriate vessel. And by protocol, I would only be given 2 attempts, but given how this patient is already unhappy with it, depending how they go, I would also ask for consent as well. And if this was not good, I would escalate to senior help and possibly require consulting vascular or anesthetics and an ultrasound-guided cannula. And this would all be done by reassuring the patient. I don't know what else I can say, to be honest.
Good. We have a whole minute and 20 seconds, so more questions. Okay.
Yep.
What are the symptoms and signs of prostatitis, and what would concern you to a severe prostatitis that may require IV antibiotics?
Okay, so the symptoms of prostatitis that I'd be concerned about would be urinary symptoms such as dysuria, frequency, hematuria. I would also be concerned about any suprapubic pain or any pain on defecation. Signs of severe prostatitis would be systemic symptoms, fever, hypertension. I don't have anything else, to be honest.
And what investigations would you order to identify prostatitis?
Okay, so I would do a urine analysis, urine MCS. I would also do STI screening using a first catch urine. I would also, in exam, do a DRE for tenderness.
Good. And final question, what are some common agents that cause prostatitis?
I'm going to say E. coli, gram-negative enteric organisms, and sexually transmitted organisms.
Nice. Done. Yeah, I don't know what I can ask you about the cannula, but sure. I could ask you, but I don't even know the answer to this question. PICC line, how is it put in?
Yeah, no idea.
I have no idea either. Just having a look regarding the anatomy very quickly. Oh, okay. So it's placed all the way into the superior vena cava. Crazy. Okay. So it's inserted in like the cube fossa and then inserted all the way to the SVC. Alright.
Wait, isn't the whole line travels the whole way?
To the SVC.
Okay.
Crazy.
Wow.
Catheter tip is literally sitting in the heart. Yeah, the end of the catheter is sitting in the right atrium. I'm not even joking, it's crazy. You'd think there would be like a big infection risk with that, but I guess they do it very sterile. Cool. Anyway. Back to this case, honestly, I couldn't even write much because you had everything that was written here. So, like a few things that you did, which were like P+, well, number one, you also looked at the patient into whether they required oral antibiotics or not. You mentioned you would consult the treating team. You would assess yourself according to the history how severe the infection was to guide your decision on whether to consult them regarding, switching to oral or not. You mentioned you look for signs of a tissued cannula, and you mentioned all the signs, so flushing, surrounding edema. Certain locations can cue you into it being tissued as well, so cube fossa can be more tissued. Everything else, you mentioned 2 attempts, you could call the anesthetics registrar, and I liked how you even brought ethics into this. It's a question of, patient autonomy and understanding versus, providing patient care and beneficence.
I needed to fill up the time.
Yeah, that was really good. And then you got everything. Did you mention, worst case, you could also call it anesthetics registrar? I think you did.
I mentioned anesthetics.
Yeah, so that's it, done. And then like the additional stuff are just on acute prostatitis. You got everything. Investigations, the only other thing they have here is prostatic fluid, MCS. I don't know how you'd isolate prostatic fluid, but I'm guessing, who knows? Because that's part of semen, right? The prostatic fluid.
Yeah,
I don't
it is.
And then,
yeah, honestly, I didn't study prostatitis because...
That's fine. I just asked you because it's at the end of my notes. But
okay.
main thing is it's like a cystitis, but they have extreme prostatic tenderness and rectal exam. So it's good to do a rectal exam on the males, I guess. And then, you got everything else. It's E. coli, Proteus, Klebsiella, typically, and then other sexually STI pathogens. Good job. Very good.
I think if I do get this station, I'll be so upset.
True, because you can't really show how much you know.
Anyway.
You said you're free tomorrow, is that right?
Yes, all we have tomorrow is KPT. But are you going in tomorrow?
Yeah, I've got to go in. I didn't go in this week so far until today, so there's a lot I need to get done, observations and stuff. So I'm going tomorrow, but if you're...
You also have convention, right?
That's at night, I'm pretty sure. I'll double check, but yeah, that's at night, so it should be fine. So I was thinking we could do the 3 other cases. We could do like a 1-hour study session, do like 3 of those cases and finish off all the 20 20 med cases. What did you think?
Yeah.
What time works for you? So if I go in the morning, I'll probably be back by around like when we started today, so maybe like 2 or 3. Would that be? What works better for you, 2 or 3?
Let's see. Because KPT is 12:30 to 1:30. Probably equal, so let's say 3.
Alright, done.
Is that too close to when you need to get ready for dinner?
Should be fine.
Okay, and I'm assuming. Do you want to keep the next session after Friday? I guess we can decide that tomorrow on Tuesday.
Yeah, I was thinking Tuesday. Monday I don't think I'd be able to do, especially all the 2021 cases. I think Tuesday would be good.
Sure. Okay, so I'll put that in tomorrow for 3 o'clock. Okay, and on another note, did you want to come to that dinner that I was posting about?
Oh, I did see it. It looks really good, but I am just backlogged right now with work, especially with teaching and stuff.
Okay.
So I've got to just get through that today. So I definitely can't come today, but I think maybe we'll see. Only because my schedule's pretty. The worst thing I don't want to do is like sign up and then not come to anything.
Yeah. That's fair.
Because
And you have your SidCon as well. You really, you're just tempting COVID at this point. I really think you'll be isolating again next week.
You reckon?
After it.
I hope not. But you're right. I am treating myself like I'm invincible, which is not good. But,
Yeah.
Right.
Sounds like fun.
Yeah, I hope it is. But yeah, I'll see you on Tuesday then.
Wait, am we doing it 1 hour tomorrow?
My bad. I have attention problems.
No, I mean, if you're busy or don't have time for it, that's okay too.
No, I should.
Should
have 1 hour.
Either tomorrow or Tuesday then.
Let's aim for tomorrow. We'll see. I'll message you like midday and confirm based on hospital.
Okay, no problem. Just let me know.
Alright.
Okay.
Cool.
Thank you.
Yeah, see you then.
Bye.
Bye. what's the latest? Like I was thinking 6. Is that too late for you? Okay. Alright, sweet. 6 should work. Cause I just gotta get a bit more study done, and then I got to cook some food. Sweet. I'll see you there, Rose. Okay.